All right. Hello, everybody. We're having a couple technical difficulties, so it'll be just a moment and we are going to get our speaker on. I see everybody's logging in right now. All right. So while Jenny works on getting set up, I'm going to go ahead and I'm going to introduce her today. She has a very impressive bio. So I'm excited to go through it. So Jenny Tate is an experienced veterinary technician who graduated in 1986 as an animal health technician. She worked in general practice 3 years, then moved to working at the Ontario Veterinary College. Jenny became a registered veterinary technician at the first seating of what is now the Veterinary Technician National Examination. She holds an RVT certificate of number 4. Just shy of 25 years at OVC, she was working in large animal surgery, teaching in surgical exercises, small animal surgery, ophthalmology, and finally settling in 23 years ago as the dermatology service technician, assisting with the instruction of the final year students. Jenny has the privilege of being the first non-faculty member in the history of OVC to be an honorary class president for the graduating class of 1999. When the vet college decided to close the dermatology service, Jenny was able to retire. This retirement only lasted a few months, though. Then she was soon working with Dr. Yu once again, and she is still a healthcare team member at the Veterinary Allergy, Dermatology, and Ear Referral Clinic in Morriston. She was on the organizing committee, is a charter member of, and past regent for the Academy of Dermatology Veterinary Technicians, and is currently the only VTS dermatology in Canada. And for those of you that are unaware, VTS is Vet Tech Specialty in Dermatology. She is also the only technician on the executive committee for the Canadian Academy of Veterinary Dermatology and is a very active ambassador for the Empathy for Itch campaign. She is an accomplished international speaker and author in her field. Jenny shares her life with her husband, their 2 grown children, and their 2 fur babies, Shinzi Lu and Willow May. So before we get started today, we're so excited to have you here today, Jenny. Reminder for our guest, be aware that your CE will come 24 hours after this webinar is completed. Please also make sure you fill out the survey. We want to hear from you. All right, so I am going to let Jenny take it away from here.
All right. Can you hear me okay?
I can hear you fantastic. Yep.
Excellent. I'm so excited to finally get back in. I don't know what happened, but every day's an adventure, right? Okay, I am going to get this party started. And let's go to presenter view. And you should be seeing my screen. Yes? All right.
Yes, I can see it.
Thanks so much, Jamie. And thank you everybody for tuning in tonight. I know it's always not easy to make time for things like this, especially in the evening. So thanks so much for joining us. And a big fat thank you goes out to Royal Canin. Without sponsors like them, and they are extremely generous, we just wouldn't be able to do CE events like this. So thank you, Royal Canin. So you heard from Jamie. Basically, I am old. I've been practicing in vet medicine for 37 years now. I've worked out in general practice, so I'm very familiar with the cases that you guys see every day. And I've also been working in derm referral practice, so very familiar with the cases that you guys have trouble with and send our way. And the last 23 years, I've been working just in dermatology. And throughout the span of my career, I've come to the conclusion that there's really 2 types of people out there in vet med: those who love dermatology and those who love to run away from dermatology. And for the derm haters, I get it. Derm cases can be very frustrating. You just get them better and then they relapse, and round we go. Really frustrating. Worst of all, our patients still continues to suffer. Even if you hate dermatology, The numbers don't lie. You need to get comfortable with these cases. This shows 4 out of the top 5 insurance claims for dogs are all skin related. So it kind of is a big fat hairy deal. And I'm not sure what happened in the United States, but here in Canada, we experienced a pandemic, and about 900,000 Canadians went out and found a new fur baby to help them get through these rough times. That's a whole lot more patients we're trying to see. And if you consider that 1 in 5 of those little critters has an underlying allergy, that is a ton more derm patients that we're trying to see at the same time vet medicine is heading into crisis where we have people leaving the field. So, how do we do more with less bodies? You really need to embrace the idea that dermatology is a team sport. And if you do want to investigate that whole concept a little bit further, I've done a few lectures through the Canadian Virtual Veterinary Symposium with community vets. So you can always check that out if you need more information on how to get your team gelling better for these derm cases. And we did that through the CAVD Dermatology Forum. We have one every year. This year, it's going to be in Winnipeg out in Manitoba, September 30th. And hooray, it's going to be in person. So I won't be talking to a little smiley face that I stick over my camera on my screen. There'll be real people that I get to talk to. Which is great. So if you're not familiar with the CAVD, I strongly encourage you to check out their website. It is a virtual treasure trove of derm information, all things derm, lots of resources there, lots of in-clinic tools. So super helpful to every vet team out there. You don't have to be Canadian to be a member. There's lots of open access stuff. And we are under the umbrella of the World Association of Veterinary Dermatology. And every 4 years, just like the Olympics, something amazing happens. And it's called the World Congress of Veterinary Dermatology. And next year, it's going to be just down the street in North America, in Boston. So if you are a derm lover like myself, I strongly encourage you to go. It's amazing. They have multiple streams of CE. These are world renowned speakers. We're talking about cutting edge leading research. So it's pretty amazing. If you're a derm hater, I suggest you go. Maybe you'll get converted. Who knows? So today, though, you guys are interested in how to handle those allergy cases, how to help them out. So quick review. In VetMed, we have 3 big groups of allergies: those insect bite hypersensitivities, environmental allergies or atopy, and those food allergy guys are adverse cutaneous reaction dudes. And they're really tough to tell apart just by looking at them. All of them, the main presenting complaint is pruritus. They're all itchy. And that guy was actually owned by one of my friends, veterinary dermatologist. We all own itchy animals. We can all relate. One thing I did want to touch on before we jump right in is how important that antimicrobial stewardship is. So last year I attended a panel. It was out of the UK. They had several dermatologists on there, some from Great Britain. They had one from Norway, and they also had a general practitioner on board. And one of the things that struck me most was hearing the GP say she couldn't actually recall the last time she'd written a script for antibiotics. So these guys are seeing the exact same cases that we're seeing, and they're managing them primarily with topicals. So that blew my little mind. I was like, wow, in North America, we are behind the curve. We really need to catch up. So how are they having success doing this? You only get good success with topicals if you have good owner compliance, and you only get good owner compliance when you have great client education. And that takes a lot of time. So where are you going to find the time? Use every team member. I can't say that enough. And veterinary technicians are great at client education. We love chatting about stuff we're passionate about. We all know the roles of technicians in all of our cases. But for myself in dermatology, I very strongly feel the bulk of my job is client education, making sure those pet parents understand right from the get-go what it is, what red flags we're picking up in that history, what it is that we're seeing on that exam, why we need to do these diagnostics, what those diagnostics tell us as results, and how that guides our treatment protocol, how we select what medication is going to work best when, and how it's going to improve the quality of their pet's life. And that's why they came to you. They know something's wrong, they want help. And when they understand that, they are completely on board. So you did hear in my intro that I'm an ambassador for the Empathy for Itch campaign. You might not be familiar with it. We've only had it for a few years now. This is our 4th year in Canada, but eventually we will take over the world and you will hear about us. It is aimed at helping veterinary clinics, vet care teams, help those pet parents better understand itch, and hopefully get them to recognize sooner what those signs are, get those patients in sooner so that we can help those guys sooner and hopefully improve their overall quality of life. And this year, our focus is definitely on how dermatology is a team sport. So we really need to be cognizant of the fact that the MVP on our veterinary care team is actually the pet owner. You can do the best workup, you can do the best diagnostics, you can have the most amazing treatment protocol. But if it's not being executed by those pet parents, it's all for naught. So, again, I can't harp enough on client education. So part of the Empathy for Itch campaign, you just go to that CAVD website. We've set up portals for veterinary teams as well as for those pet parents. And there's tons of resources there. We did a whole survey across Canada. What questions are you asked most by those owners of itchy pets? And we did little videos answering each question. So any questions those parents have should already be answered when they peruse this website. So in a perfect world, when your front desk staff are booking that appointment, yep, we got you booked in. You're going to see Dr. Clark on Wednesday at 9, but you have homework. You need to go to this website, download this dermatology history form, fill it out, and send it back to us before your appointment. And take a look around at what's on there. It's going to answer a ton of questions that we know you're going to have. This is going to speed up your whole derm appointment. And that's the plan, is to get them educated before they even get in your door. So it just speeds up the whole process for you. And that derm history form is going to give you a succinct history. So it speeds up, again, that most important part of your whole derm appointment. So today, here we are, when to use what in your allergy patients. I'm sorry to say, but for you to actually know when to use what, we need to do a little refresher course in the immune system. And I do have a great big disclaimer here. Immunology is ridiculously complicated. So I am doing something here that is extremely simplified. It is not all encompassing by any stretch of the imagination. If any of you out there are immunologists, I do sincerely apologize in advance. So here we go. The immune system is made up with 3 big chunks. So we have barrier immunity, innate immunity, adaptive immunity, and all of those together make up the immune system, which is meant to protect us from any scary pathogens or antigens trying to break through into our entire system. So barrier immunity is pretty straightforward, made of a bunch of barriers. So we're talking about the skin. The skin is amazing. That's why I'm here, because I'm so excited about it. Does lots of things, keeps good things in, keeps bad things out, acts like a wall. It's also covered in antimicrobial acids and oils and peptides. We also do this crazy desquamation. So we shed off all those dead skin cells, taking a bunch of those scary pathogens with it. As well, we have a local immune system in place ready to jump. Other barriers that we have are kind of like the skin. We're talking about the mucous membranes, that whole gastrointestinal tract. And then we move into that innate immunity. So innate immunity is right in the name. It's something that is innately there. It's just there. It is non-specific. It doesn't matter which pathogen comes along, everybody gets greeted the same way. And it's made up mostly of a bunch of cells who we know very well. So our white blood cells, we've got our neutrophils who are our first responders, get there, gobble up the bad guys. Then eventually our heavy hitters, those macrophages come in. We'll have eosinophils if we've got parasites or allergies going on. Same with our basophils. We've got those mast cells that we see with our allergic responses. And then we also have those dendritic cells. Those are those Langerhans cells. They are like the patrol officers of the immune system. They go out looking for bad guys, catch them and bring them in. We also have another part of the innate immune system called complement. And I was not familiar with this until I started working in dermatology. So we will touch on that because I think it's important everybody understands. We also have the adaptive immune chunk of our immune system. And that key again is right in the name, adaptive. It adapts to which specific pathogen it is confronted with. So it's a very specific response. And this happens through the use of our lymphocytes. So we're going to talk about a couple of those guys, our B cells and our T cells. So if anybody doesn't know, that gentleman on the right there is Mr. T. And all you really need to know, because I'm old, is that he is cool, he is a man of action, and we all think he's wonderful. Okay, our B cells, just like their name, they're busy little bees. They're always making antibodies, and those antibodies are going to swarm any of those pathogens. Mr. T, I already said, he is a man of action. He decides what to do and gets the job done. That's bottom line, no bones about it. So let's compare our innate immunity and our adaptive immunity. So innate definitely is first line of defense. Our adaptive or cellular defense immunity is our last line. So innate, we said not specific. Doesn't matter who comes along and get treated the same. On the opposite end of the scale, our adaptive immunity is very, very specific. Innate made up of a bunch of physical barriers like the skin, a bunch of chemicals, acids that we see on the skin, mucous membranes in the stomach, through that intestinal tract, made up of a bunch of our white blood cells, so tons of phagocytes, finding a bad guy, engulfing them, chewing them up, spitting them out. Where our adaptive immune system works mostly with our antigen presenting cells. And then our lymphocytes take over from there. So those B lymphocytes produced in the bone marrow, very special, and they work mostly in what's called a humoral response. So it's an antibody response, but it happens kind of in those interstitial fluids. So not inside any particular cell in the body, just kind of free floating around. Lots and lots of antibodies. And these lymphocytes, the B lymphocytes, are also known as plasma cells. So you can actually see them when you're doing your in-house cytology. And then our other guys we talked about are T lymphocytes. And there's two kinds of those actually. They start out in the bone marrow, just like our B cells, but then they undergo some very rigorous training in the thymus. These guys have to make good decisions. And if any of their testing isn't up to par, they're just plain old gotten rid of. So we have two kinds of T cells. We've got our T helper cells, which help decide what to do. And then we have our cell-mediated response guys. These are the assassins of the immune system. There are cytotoxic T cells, or our natural killer T cells. You might know them as. So super quick review on what happens. So our Langerhans cell, our dendritic cells out patrolling the grounds, see someone suspicious, reaches out, engulfs them, chews them up, takes an itty bitty piece of them and mounts them on a service. And then he goes and runs to the nearest lymph node to find out what to do about it. So we can have one of two things happen. Our T helper cells help decide what's going to happen. So we can either have a Th1 response, which is an anti-inflammatory response, where we get a lot of chemical messengers sent out, cytokines called interferon, which is an anti-inflammatory response. Then the body makes memory of that. So next time we run into them, we already know what to do. And a whole bunch of really good antibodies are produced. Those are called IgG antibodies. That's our anti-inflammatory response. That's our Th1 response. On the other side, we can have a Th2 response, where it is a pro-inflammatory response. Everybody gets all excited. This guy should not be here. We need to mount a defense. All the bells and whistles go off. A bunch of chemical messengers, cytokines are released, filled with a whole bunch of interleukins. Those guys are troublemakers. They start that whole inflammatory and allergic cascade. So the same thing happens. The body makes a memory of that, so they know what to do next time they run into it. And some nastier antibodies are produced. Those are called IgE antibodies. E stands for evil. We don't want that pro-inflammatory response, where our IgG antibodies are the good guy antibodies that we get when we have our anti-inflammatory response. And when we're doing our immunotherapy, our allergy shots, we're trying to shift, we're trying to retrain that immune system to switch from a Th2 response over to that Th1, that anti-inflammatory response. All right, let's talk a little more about our lymphocytes. We said they are free floating in that interstitial fluid, so it's a humoral response, but they are part of an adaptive immunity. So they get help adapting from our T helper cells. This all happens when the pathogen is not inside any cell in the body. So the T lymphocytes are actually covered all over on their surface with about 10,000 cell-bound, membrane-bound antibodies. So they're all these little Y-shaped guys, and they have a very specific area where antigens bond to them. It's called the epitope. And there are about 10 billion different specific moldings, if you will, that will trigger a response. So the chance of us running into something greater than 1 in 10 billion things that our immune system can't handle is pretty darn slim. So I would say the immune system is pretty freaking amazing. And this is a very specific mold. It has to be an exact fit to trigger a specific response. So it's very much like a lock and key mechanism. So once that B cell becomes bound to that antigen, that pathogen, it becomes partially activated. And then it looks to its buddy, the T helper cell, to help it decide what to do. And the T helper cell will say, hey, we need to get on this, start cloning yourself. So they clone themselves, they get a whole bunch of clones. Some of those clones will become memory cells so that the body knows what to do next time we bump into it. We're all ready to go. Some of those cells will become effector cells. And those effector cells are little antibody factories, and they can actually spit out up to 2,000 free floating antibodies per second. So just think if you got a whole bunch of these guys working overtime, it's a pretty amazing response that we can mount right away. And those antibodies will go out and like pounce on that pathogen. It's like sugar coating. They jump all over them. And hopefully that interferes with how well that pathogen is going to work. So hopefully it slows down that disease process. And it also goes through, it starts something called opsonization, where it like tags the pathogen for our other phagocytes to come along and take them out. So it's pretty amazing. It blows my mind, to be honest, that all this is going on this microscopic cellular level. Remember, these B cells are covered all over with these receptor sites. So they can actually tie up a whole bunch of pathogens at once. It's pretty miraculous. And then something else happens too. Once that B cell has been told what to do, it actually becomes a phagocyte as well. So it will actually engulf that pathogen, chew them up, and take an itty bitty little piece of it and mount it on its surface. And then it will run to the nearest lymphocyte and the whole thing starts all over again. So it just kind of keeps multiplying exponentially. And it's the same phagocytosis that we talked about earlier with our white blood cells. So there's actually three types of antigen presenting cells. There's our B cells once they're activated. There's those dendritic, our Langerhans cells. Those guys who are out patrolling the grounds. And then our really heavy hitters are our macrophages. And macrophages are pretty interesting because they can engulf multiple pathogens, chew them up, and then go act as an antigen presenting cell, where our neutrophils can only take out one guy at a time. So there are heavy hitters. All right, our adaptive immune system, we said that B cell gets activated, clones itself, makes memory cells, makes effector cells, shoots out a whole bunch of antibodies. What happens with our T cell? Basically the same thing. So you'll notice if you go through any physiology in the body, somebody came up with an amazing system. And when that system works so well, it tends to be used multiple times throughout the body. So our T cells basically go through the same thing as our B cells. So they get activated by that little name tag. It's called mean histo something complex. I'm blanking on it right now. Mean histocompatibility complex 1. That's that little name tag that they take from the pathogen. They chewed up and they spit out a little bit on the surface. So when our T helper cell gets activated, that comes in contact with that exact little name tag and knows what to do. And it will clone itself. It will also make some memory cells and also some effector cells. So what do the effector cells make? They make cytokines. They make all kinds of chemical messengers. So we talked about them making interleukins, which are the troublemakers. We also talked about them in our anti-inflammatory response, making those interferon cytokines. So they tell all the other guys what to do. They communicate with those cytokines. Now, we can also have a cell-mediated response when a cell actually becomes breached by a pathogen, like when a virus gets into a cell. That works a little bit differently, same kind of idea, but that's when our assassins come in. That's when we get those cytotoxic T cells, those natural killer T cells coming in. They get activated and they actually kill the cell that's been compromised in an attempt to save the rest of the body. It's just amazing to me how this whole thing works. So again, those cytokines, they're messengers. They like get those T cells to kick everybody into high gear. They can also tell our B cells to divide more quickly. Come on, make more clones. We need more stuff going on, so that we have even more of those free floating antibodies running around. And again, if they're the troublemaker, the pro-inflammatory, we get that inflammatory cascade starting. So bottom line, T effector cells make messengers that tell other cells what to do, get everybody all ramped up. But that's our Th2 response. Remember, we can also have that anti-inflammatory response where instead we get that calming interferon that's produced. Okay, Smokey. Quick review. Remember our antigen presenting cell? Found someone weird, digested it, took that little name tag, so that major histocompatibility complex, stuck it on their cell surface, went and found somebody, a lymph node. Hey, what do I do with this? I found this. But when our cell itself becomes compromised, we don't have that happening. Instead, the compromised cell kind of puts up a little white flag. Help me, please. I've been compromised. So that one is major histocompatibility complex 1. With our antigen or our pathogen being engulfed, that is 2. So slightly different things. 1, so number 2, our MHC2, is when we found an intruder and all the alarms go off. And that's when our T helper cell comes along. But with our compromised cell, it's the MHC1, and that's the little white flag that says, help me, please, take me out. And that's how our assassin cell, our killer cell, our T natural killer T cell knows who to take care of and who to take out. And when that gets activated, it also clones itself and it also makes effector cells. And it's the effector cells that go ahead and use proteins and enzymes to take out that compromised cell. And those memory cells go looking elsewhere, see if there's anything more that they need to deal with. All right, so we know that all of this ends up being some kind of inflammatory response. So in the body, our patients, that looks like redness, swelling. We get often heat and pain because it actually sensitizes those touch receptors in the skin as well. So things are interpreted as more painful than usual. So what's actually happening out there on the battlefield? There's some kind of trauma, maybe it's scratching or a puncture, something damages cells, and out of those cells go a whole bunch of phospholipids or little cytokines, little messengers that say, help, there's trauma in this area. And that can trigger our mast cells. And our mast cells, when they degranulate, they wreak a bit of havoc too. They cause a whole bunch of vasodilation, which of course adds to our swelling, redness, heat. And when we have vasodilation, it actually allows white blood cells from the bloodstream to leak out into those interstitial fluids. So that's how our neutrophils get out there to the areas that need help, and eventually our macrophages as well. Now, those two we said are non-specific immune system. Doesn't matter what pathogen they come across, they're just going to try and eat them. Doesn't matter. At the same time, we have a more adaptive, more specific thing going on as well. And that's with our dendritic cells or our antigen presenting cells. At the same time, there's something else that's going on, and this is called the complement system. So complement is a protein that lives in the plasma, so the fluid portion of the blood, and it actually becomes activated by the cytokines when there's an inflammatory response going on. It actually gets activated when those antibodies bind to that pathogen. And it does a few things. It does actually some really interesting things. It starts what's called opsonization, so it kind of sugarcoats that whole pathogen. And once it's on there sugarcoating, it starts to beat up the pathogen by lysing it, by poking holes in it. And it also enhances inflammation because it tags that pathogen and makes it easier for our phagocytes to find and take them out. So it's interesting and important part of our whole immune defense, just trying to destroy those invaders. So in conclusion, we've come to the end of our immunology. Thank goodness, you're saying. We have B cells producing antibodies. The two ones that we're concerned about in our allergy patients are those IgE antibodies, the evil ones that we see when we have an inflammatory response, that Th2 response that everybody gets too excited, or the IgG antibodies, also called immunoglobulins. IgG are the good guys, and that's when we have that non-inflammatory response and we get that interferon produced. All righty. Right about now, you're probably like, why did we go through all of that? It's so that now we can actually talk about the medications so you can understand how they work and when you should be using them. Corticosteroids, cyclosporin, oclacitinib, lokivetmab, and I'm going to touch on allergen-specific immunotherapy. So we said, unfortunately, in dermatology, the main presenting complaint is pruritus. And when they scratch, we end up with all kinds of stuff going on, all kinds of inflammatory cascades, allergic cascades, all messages being sent by those chemical messengers, those cytokines. And there's actually 3 different types of itch. So psychogenic, when our brain chemistry is a little wonky; inflammatory, which is the bulk of what we see in our allergy patients; but also neurogenic itching as well. where those messages are being sent from the neuron up to the brain that says, hey, you're really itchy here. So let's take a look at that inflammatory cascade. So when a cell gets damaged, it spills out a whole bunch of phospholipids, more chemical messengers. And when those guys get out, they react with phospholipase, and that is the problem. Then they get changed into arachidonic acid, which then gets changed into prostaglandins, which cause a lot of trouble with inflammation throughout the body. So what do corticosteroids do? They actually inhibit phospholipase. So we cut that whole cascade off before it starts. So as a result, it takes away inflammation. So those are our anti-inflammatories. And you guys know all the usual suspects here. There's no big surprises. There's a few different flavors, a few different strengths, a few different guys, small, bigger, biggest, as far as hard hitting goes. And we also have those topical steroids that are doing exactly the same thing. One of my favorites is mometasone. It's a steroid that actually stays in the skin with very minimal systemic absorption, because we all know our pet parents, hey, that topical stuff worked, I'm going to keep using it. And they tend to overuse those topical steroids. So beware. Okay, we talked about steroids. Next on our list is cyclosporins. Somebody somewhere figured out that they can take fungus from the soil and use that to actually prevent organ transplants being rejected. Like, poof, blow my mind. Who came up with that? I have no idea. But then someone else came along and said, hey, isn't organ transplant rejection just a form of an allergic response? Maybe we can use this in vet medicine to treat our canine allergy patients. There you go. And it's just gone from there. So cyclosporin, a little bit about it. It's a large lipophilic molecule. It has to be solubilized before it can be absorbed in the intestine. Its job is to be a calcineurin inhibitor. And you guessed it, by my friend, Mr. T here, we're going to talk a little bit more about our T cells and what happens there. So when we have that antigen triggering that receptor site, we get a whole bunch of calcium released, which in turn activates calcineurin. Why do I care about calcineurin? Calcineurin is actually like the push button to flip the switch of that T cell, to turn the T cell on. It relocates the T cell inactive nuclear factor, and it moves it from the cytoplasm of the cell into the nucleus, which releases all the genetic coding for the cytokines there. So it's actually the flip switch. And when we inhibit calcineurin, we stop that switch from being triggered. It cannot be turned on, which is pretty amazing. We have stopped an entire immune response just by using a calcineurin inhibitor, which is pretty crazy. And even though we've done that, we've taken out that specific adaptive immunity, we still have that whole chunk of the immune system that is our humoral immunity, or our non-specific immunity. So it's pretty amazing to me, and it's brilliant. The only time that this really isn't so fabulous is when we don't really want to shut off the ability to have those cytotoxic T cells. So if we have like a dormant virus that's being kept in check by the immune system, we don't want to use our cyclosporin. If we have someone who has a history of neoplasia and we want to keep those cancer cells in check, that's not a great candidate to be using cyclosporin in. So watch out for that. Definitely a no-no. We do use atopica as an immunomodulator to help us with some other immune-mediated skin diseases because it works so well. Some other important stuff to keep in mind, pharmacokinetics, it travels through the P glycoprotein pump, so the P450 pump. You may have heard of someone who's taking medication and can't have any grapefruit juice. That's because it's competing with the P450 pump. A lot of drugs, a lot of things use that pathway. And when they're competing, you can really mess up the concentrations of those drugs actually being delivered. So you can see here a whole list of medications that are not weird and wonderful. It's stuff that you guys see all the time, and those can increase the concentration of our cyclosporin being delivered. So pay attention. You may have to adjust your dose if you got something else on board. As well, it's mostly metabolized in the liver. So if you have someone on atopical long term, you really should be monitoring their blood every 6 or at least every 12 months, just to make sure they're ticking along okay. It does take a long time for it to build up into significant levels in the skin. So it can take us 4 to even 6 weeks to get to maximum effect in the area we need it, which for us in derm is in the skin. We said there's a bunch of drugs that can make your levels too concentrated. There's also other drugs that can do the reverse and actually dilute your dosing. So again, these are not crazy drugs, stuff you see all the time. So pay attention to what your patients are on. And it's not that quick fix. It's going to take at least 4 weeks for us to see the real effect of that medication. If your animal's a train wreck, we're going to have to manage symptoms until we get that cyclosporin to full effect. And one more point about cyclosporin is it can evaluate serum glucose. So if you're using it in someone that does have diabetes, really keep a good eye on them. Alrighty, oclacitinib. This is also a very cool drug. It's an immunomodulator, and it works by blocking the expression of Janus kinase enzyme. So it's called a JAK inhibitor. And those Janus kinases are the ones that send that neurotransmission from the nerve cell up to the brain and tell you you're itchy. So if we block those enzymes, the message doesn't get through. The patient doesn't realize that they're actually itchy. Now, those Janus kinases are actually used in a few different systems in the body. So I'm always a little bit leery. I'm always the what if guy. So if you are using Apoquel long-term in somebody, make sure you're keeping an eye on their blood work. One of the processes that those Janus kinases are involved in is hematopoiesis. So you do want to keep an eye on them. Definitely not using it in anybody less than a year of age. This is also a great website to check out. It's called itchcycle.com. They have some amazing animation there, and we're borrowing some tonight. You can see there's our T cell. He's decided to have a Th2 response. He's too excited. He's releasing all those interleukins, and this one is interleukin 31. And that little stinker is a troublemaker, floats around until he gets to that nerve cell and he settles into a receptor site. And as soon as he's in that receptor site, it triggers the expression of those Janus kinase enzymes, which sends that neurotransmission up to the brain. So somebody thought, oh, maybe we should just plug those sites and stop the expression of the Janus kinases. So they made something that actually fits onto that site like a plug. And if you're plugged up and you're not expressing those enzymes, you're not getting that neurotransmission, you have stopped the itching, which is pretty cool. Apoquel is really interesting. It's cleared very quickly from the body. So there is no reason why you can't use that on an as needed basis. So if you've got a day where your patient's really itchy, give them the Apoquel. If the next day they wake up, they're doing just fine, he doesn't need it that day. So it's really nice that way. You can give it as needed. It's also a nice way to start out with a diet trial, tag that on board, take care of itching while you're giving your diet trial some time to see if it's effective, if you're on the right diet. All right, next up, Lokivetmab. Who doesn't like saying Lokivetmab? This is why derm is so cool. So this is an immunotherapeutic. It is not a drug. It is a canonized monoclonal antibody, which again, poof, is brilliant. So it's been disguised to look like a canine antibody so that when it's floating around, the immune system doesn't recognize it as being foreign, so it gets to work. And because it's an antibody, its job is to tie up and bind to things. And it has been created to specifically bind to that interleukin 31. So if it binds to interleukin 31 is not going to make it to that receptor site to trigger the expression of those Janus kinases to send that neurotransmission up to the brain. So they kind of work like a bunch of little mini sponges floating around. It's that once a month injection, and it's very patient individual response. My own dog, I can actually get away with one injection at 1 mg per kg for 12 weeks. Some dogs it doesn't work in, other dogs it works great. If you live in North America, our dosing here is 2 mg per kg. If you happen to live in Europe, their dosing is 1 mg per kg. So for those long-term users, at least get them started, give it a fair shot and start out at those 2 mg per kg. And if they do great and they're doing great for a few injections, go ahead and see if you can get away with that 1 mg per kg dosing, because this is a long road that we're heading down. So if we can stretch out those dollars to help us manage that, that's great. So again, if the messenger doesn't get there, the message doesn't go through, and hopefully we'll get 4 to 8 weeks of relief. So another immunotherapeutic, this is our allergen-specific immunotherapy. This is our allergy shots or drops that we make up for our patients. We do not do allergy testing to see if a patient has allergies. We only do allergy testing to figure out what to put into immunotherapy. So the immune system has this tricky balance between Th1 and Th2. And I said earlier, with our immunotherapy, we're trying to switch from that Th2 response, too excited, to that Th1 response where everybody remains calm. Okay. If we actually have too much of a Th1 response, sounds like that would be a great thing. It's not actually, because then things get a little out of control. So we can see overgrowth of normal commensal organisms like yeast, bacteria. Maybe we have a relapse of ringworm, so some fungal infections get out of hand, or demodicosis, or a dormant virus like papilloma rears its ugly head. On the other side of the scale, if we have too much of a Th2 response, what do we end up with? Allergies. So again, we do the allergy testing to figure out what to put into immunotherapy. There's an injectable version, there's an oral version. They both work equally well. It just depends on that specific patient and their owners what's going to work best in their hands. And this is not a quick fix either. This takes a minimum of 3 months to see any kind of a response. And then typically we say anywhere from 6 to 12 months to see just how effective it's going to be for that individual. Our goal with immunotherapy is to, over time, be able to minimize the use of other systemic drugs to keep that patient comfortable. Okay, quickly, we're going to talk about mast cells. So mast cells full of granules, those are histamine granules. When they degranulate, histamine goes everywhere and also triggers havoc, including on blood vessels. It attaches to receptor sites and triggers that vasodilation, which allows our white blood cells to escape, and we get swelling, we get inflammation, the whole shebang. But what our antihistamines do is they block those receptor sites. So when those histamine granules come along, they have nowhere to attach, so we don't end up with that allergic cascade. There are a few different generations of antihistamines. First generation was not really very specific. It leaked into the central nervous system, and those are the ones that cause us to be drowsy. Those are the ones we reach for if we're feeling a little bit nauseous. Our second generation ones tend not to cause any sedation. The names you guys all know. How effective are they? They work up to about a third of dogs, but if you find one that works, that's fabulous. That's a really nice adjunctive therapy to be able to use in your patient. And if you have a patient that's itchy and responds well, you can use a second generation, a non-drowsy antihistamine in the morning. And then if they're an itchy guy at night, go ahead and reach for that first generation to help them sleep and help that family sleep through the night as well. Makes everybody happy. Essential fatty acids, you guys, I'm sure already know about. We have omega 3s and omega 6s. We use the omega 3s to manage inflammation. We use the omega 6s to help enhance or improve that coat, that hair coat, and that skin barrier. So different doses depending on what you're going for, what you're using. Um, Other products that are out there that can be helpful. Everything is multimodal in derm. So this is a kind of new one, the Retinol Ultra. It uses PEA. I'm going to call it that because I've tried many times to pronounce that, and I'm sure I'm still saying it wrong. But PEA actually helps stabilize those mast cells so that they don't degranulate so easily. And they also help at the cannabinoid receptors in our skin cells to improve homeostasis. So to make our skin cells work better and also improve how well our macrophages work as well. So helping out that immune system and that barrier system. We also use a ton of topicals, and the future says we'll be using even more. And there are a bazillion products out there. And in the States, you guys have way more to choose from than we do. There's literally something for everything you can imagine. But there's really only so many reasons to be bathing a dog. Most of their topicals are bathing. They're stinky. Why are they stinky? For us in derm, it's usually because they have a secondary infection that's making the oils on their coat rancid, so that stinks. So we definitely want to reach for things that have an antimicrobial action. Sometimes we have keratinization disorders. We want to get rid of all that extra dander or crust that's on there. Sometimes they're super greasy because their sebaceous glands are out of whack, or sometimes they're really dry, so we want to add more moisture. And then we have other products we reach for to, again, help improve that skin barrier so it works better. So some ingredients are multitaskers. So you see them on a lot of labels. Sulfur and salicylic acid work together. They're antibacterial, antimicrobial. They're also keratoplastic. So they help normalize that skin layer as it turns over. Keratolytic helps get rid of all that dander and crust. And then benzoyl peroxide as well, also a multitasker. Benzoyl peroxide, though, can be irritating. It's a super degreaser. So if you're using that, warn the owners if they think it's kind of irritating the skin, it is. So you don't have to keep doing that. And then all the usual suspects, again, for helping to moisturize and improve that skin barrier. The Duxel line has an interesting ingredient called ophitrium, also a multitasker, also does a lot of cool things. They have it included in several of their lines, everything from antimicrobial, antiseborrheic, calming. The bottom line with our topicals is you want to be familiar with what the ingredients are and then go back to your clinic and look at what you've got stocked on your shelves, because a lot of people accidentally have actually the same product with a different name on it. So just make sure you're not doing that. Another little aside with our whole shampoo thing, if you have a thick coated dog, some of these shampoos, at least in Canada, are $50 a bottle. If you have a thick coated dog, tell the owners we want to get that expensive medicated shampoo down to the skin. Let's use first a regular old grooming shampoo, get the initial grease and dirt out of the coat so that the expensive shampoo can then reach the skin. And of course, you want to coach them through how to actually bathe, how long our contact time should be, and so on. So another shameless plug here for the CAVD. We have a list of all the available topical products in Canada, what's in them, when to reach for them. There's all kinds of different delivery mechanisms. So some things can be slow release. Some of our topical products are actually absorbed by the sebaceous glands and then slowly expressed out in the sebum or oils on the skin. Another big topical talk about is our steroids. So I'm not sure if you guys have this in the States. We have in Canada and absolutely love it. It is hydrocortisone acipinate. So because it's an acipinate, it does not, it has very minimal systemic absorption. So it pretty much stays just in the skin, which is great. Another thing we'll sometimes reach for is those eardrops. If we have a focal lesion on the skin, we'll use those on there. Some of them have a great topical steroid in them called mometasone. Again, we have very minimal systemic absorption. And I think that's super important because a lot of our owners like what those topical corticosteroids do, and they tend to overuse them. So at least if we're using it, something that stays in the skin, we're trying to minimize systemic absorption. And anytime we're putting together a treatment protocol for our patients, we try to get the owners involved and find out what's going to work in their world and how easy can we make it for them. So maybe we shampoo once a week, we use sprays or mousse a couple of times a week on the non-bath days. Or maybe we have something very focal and some wipes will work for us. So it's all very individual. It all depends on what the history is, what that means, where we're going with our patients. And history, that should include a response to steroids. So if we have a great response to steroids, that tells me we have a big chunk of the equation is going to be our environmental allergies. Our food allergy guys have minimal to no response to corticosteroids. So it helps you tease out a little bit. We are always investigating the role that a diet or a food allergy might potentially be playing. Always. These animals have to eat. So they have to eat anyways. If we can cure them or make a big chunk of their issues go away with finding the right diet, it is worth doing. And which diet should you use? It depends on that individual. We need a thorough history. We're always reaching for either a novel protein they've not had before and a protein that is not going to cross react with something they've had before. It depends where exactly on that little protein chain they have a problem. So, what they're actually allergic to, which protein we want to stay away from. So I don't know how different that protein chain is in a chicken versus an emu. They both have wings, they both have feathers. How different are they really? I don't know the answer. So we would stay clearly away from anybody else with wings or feathers. I also don't know how different a cow is from a buffalo, from a bison. They're all ruminants. So, how different is that from a sheep versus a goat? I don't know the answer. So, we steer clear of all of those. If you have somebody who really want to cut to the chase, maybe a hydrolyzed protein is the way to go. Or especially we reach for our hydrolyzed proteins in animals who have a history of adverse gastrointestinal reactions as well. It's a nice way just to calm down the gut. It's kind of pre-digested for them already. But diet trials, huge component of client education. They need to understand how to properly do a trial or it's sabotage from the beginning. Golden rule, always treat for parasites, always clear up those secondary infections. Cats, those cute little creatures that we all love, I am certain are aliens that were left behind after the pyramids were created. They are weird and wonderful, which is why we love them, but that also extends to their allergy issues. So cats get craziness like eosinophilic granuloma complex. And this one dermatologist, Dr. Kovalek, tried to break the code. He tried to figure out what area of the cat gets itchy with which allergy they have. Basically, if you look at a cat sideways, they go after their belly and a little bit after their head. If we're looking at fleas, definitely that rump is involved. But if they're got a food allergy, they will really go after their head and most especially their neck. And these guys will literally rip their skin right off. So you got someone going after their head and neck, please do a diet trial. Take a look at that. In a cat, if you have some golden crusts on the head and those claw beds, start thinking about pemphigus. They'll also get crusties around the nipples. I don't know why. They're cats. Dermatophytosis is always on the board, especially for our smushy face guys like our Persians. Cats basically don't get ear infections, but they do get those nasopharyngeal polyps. Few rules of thumb for dogs. Anybody with issues with their skin less than a year of age, start looking at a diet trial. Anybody older who's been perfectly fine up until their middle age, 6, 7, 8 and above, start looking at an underlying food allergy. Are they refractory to steroids? Yeah, okay, we're nudging along that food allergy. If they have symmetric alopecia, look for something endocrine, something coming from the inside out. They have lesions over the dorsum. We swing a little more towards food, on the ventrum, a little more towards environment, ears, feet, and rears. So they got trouble with their butt in any form, any gastrointestinal issues, anal pruritus, trouble with the anal glands, start looking at food. Recurrent pyodermis, look at what their endocrines issues are doing. Are they hypothyroid? Is that working okay? Because those infections are always secondary. So when to use what? It depends on your problem list. Do we need to take care of inflammation? Do we need to do that fast, or do we have more time? Are they itchy? Why are they itchy? Did we clear up those infections? Is that why? Or are they itchy because of an allergy? Did we rule out parasites? And once we've got them feeling good, it's important to think about preventative maintenance protocols. Is it someone who definitely has a seasonal issue? Can we start to load them up with some cyclosporin 4 weeks before spring comes so that we lessen any issues they have because they only have trouble in spring? Diet trials always. So yes, we're always looking at multimodal treatment protocols, and it's always lifelong. We don't have any cures. So it's always worth doing that diet trial. So when do you use what? Well, here's that vicious circle. And there's a bunch of ways we can jump in and help those patients. We can take care of improving that skin barrier so it works better. We can jump all over those cytokines that are being released with things like our Apoquel, Cytopoint, of course, our corticosteroids, our anti-inflammatory for atopica. Or if you don't want to do any of that, maybe something like this will work. I don't know. I kind of doubt it, but our goal is always to get our patients back to living the lives they're meant to be, but it is a long road. Those owners need to understand it is for life. We are looking at management versus cure with those allergy guys. There will be bumps in the road. So when they come along, they're like, okay, they said this might happen. One last thought for you guys. I don't know if you know, but the number one reason people leave clinics is due to unresolved skin issues. And it does not have to be like that. It's all about client education. Can't stress that enough. All righty. I think we have a couple of minutes maybe for some questions. Did I lose you there, Jamie? Should I stop sharing my
You,
screen?
nope, you are good. That was fabulous. First off, the pictures, phenomenal. Love them.
Ah, good, good, good.
Very like kept me completely into this talk through and through. Um, I'm
Great.
also really excited about empathy for itch using that site, that
Yes,
efficiency, that client education. I'm pretty excited about that.
yes.
Um, and as someone who has a cat on Atopica, I appreciate the tips.
Yep.
And before I go to if there's any questions, I have one more thing to say. I love that you talked about how shampoo, you're aware it can be expensive, and using that more inexpensive shampoo to get that first wash in and then go back with the expensive one. I think that's
Yeah.
huge.
It is. And helping those owners do something that's not always bathing is super helpful too. If you can bath once a week, maybe you can do something else a couple times during the week, spray, mousse, whatever.
Yeah, getting them on board, making it easier for them to help with the treatment plan.
For
Um,
sure.
I am trying to see if I have any questions coming in. I know people were probably doing what I was doing and writing notes left and right as quickly as possible. Um, guys, don't forget to please fill out the survey. Let us know about what you thought about tonight. Um, I would like to, yeah, you're getting a lot of love. People
Oh,
loved the
good.
lecture. People loved seeing Mr. T all over the screen.
Oh, good.
Real quick, because we have a little bit of time, can you quickly tell everybody what a VTS in dermatology is and what that path was for you?
Okay, so I'm old, so my path was weird. So a VTS is a veterinary technician specialist. If you relate it to human medicine, it could be akin to a nurse practitioner. Obviously, we don't diagnose and prescribe, but you've got a lot of extra knowledge there, and you can certainly help out your docs by taking some of the load off of them. My journey was weird because I'm old. I went to derm conferences, got sucked in, got to know the same technicians that had the same interest. And over time, we were like, I keep hearing about these specialist groups, but there isn't one for derm. So eventually we decided, let's make one for derm. So that was a long and painful labor of love. And so let's see, we started hanging out probably in 2004. And in 2015, we got our provisional recognition from NAVTA as a specialist group. So um, it's a long trek, but now that we've laid the groundwork, if you're interested in becoming a specialist, it's very similar to any of the other specialties. So anesthesia, dentistry, whatever floats your boat. You buy a packet and it takes you at minimum a year and a half, but typically 2 to 3 years to get it all organized. And you submit it. If it gets approved, then you, yay, now get to go ahead and write a big fat exam. And when you pass the exam, then you're a specialist in that area. So hopefully that brings a lot of knowledge to wherever you are, and it elevates the level of care where you are.
Yeah, I think, I graduated and got licensed back in 2013, and I actually was unaware that VTSs existed until probably about 8 years, 7, 8 years into my career. So I always like to take an opportunity to talk about it because there's so many different VTSs out there if you're passionate about something.
Yeah, yeah, and that's the whole key for any tech that's starting out. I didn't find derm for me until I was 14 years into my career. So just keep looking, find what floats your boat, find your passion, and the rest just kind of happens from there.
Perfect. Well, like I said, you still have plenty of love coming in here. But thank you so much for being here. Thank you for making this conversation exciting for all of us and being it's very intriguing and educational. So I appreciate your time. Thank you for being here
Great.
tonight.
Thanks so much for asking me. I had a blast. Thank you.
Not a problem. All right. Thank you all so much. Everybody have a good rest of the night.
All right. Bye bye.